Hello everybody. Today we'll be talking about the treatment of rheumatoid arthritis. So, the problem with rheumatoid arthritis is that there are many classes of drugs that can be used. So, many times, what students or even practitioners find confusing is that what are the drugs that can be used and will be most effective, and what are the drugs that should not be used in certain conditions, and what exactly are going to be the side effects of these drugs, and what are the various combinations that we have to use. So today we'll be talking about these. Let's start with the classes of drugs that can be used in the treatment of rheumatoid arthritis. So the first class that we all know are DMARDs, which are disease modifying anti-rheumatoid drugs. So in this class there are mainly four drugs. The first is methotrexate, second is hydroxychloroquine, third is sulfasalazine, and fourth is leflunomide. So the first drug in this group is methotrexate, and it is the single most important drug that we have to use in the treatment of rheumatoid arthritis. Now, the second class of drugs that we have to use is biologics. But the problem with biologics is that it is only IV or subcutaneous only. There is no oral regimen in this. So because of this, many patients find it difficult to take the drug at home. Another added disadvantage of biologics are that compared to DMARDs and small molecules, they are very expensive. So the first class in this biologics is anti-TNF alpha. Now, among all the biologics that we'll be discussing, these are the most effective drugs. So the reason for anti-TNF alpha drugs being the most effective among all the biologics is that they are actually acting on TNF alpha, and TNF alpha is the key pathogenic cytokine. So whatever inflammation and whatever articular manifestation and extra-articular manifestation that are occurring in rheumatoid arthritis are actually occurring due to TNF alpha, and these drugs are the ones blocking it. But because they are IV, subcutaneous, and they also cause a lot of immunosuppression, they are not routinely prescribed by the physicians. Another added disadvantage of TNF alpha is that they can cause anti-TNF alpha drugs is that what they do is they cause reactivation of tuberculosis, or they can cause a reactivation of hepatitis B, or they can even cause drug-induced lupus. So because of these various side effects, they are not routinely prescribed. So among the anti-TNF alpha drugs are infliximab, etanercept, satralizumab, adalimumab, and golimumab. Among these, etanercept is the one that is most commonly used, and the reason for its use is that it is a fusion protein. So because it is a fusion protein, the various side effects like the reactivation of hepatitis B or a reactivation of COX is seen relatively less with etanercept compared to the others. Another drug is anti-CD20 rituximab. Rituximab is a drug that is mainly used in vasculitis. Then there is anti-interleukin 1, which is anakinra, anti-interleukin 6, which is tocilizumab, and anti-CTLA4 FCIGG, which is abatacept. Now coming to the third class, which is the small molecules. Now small molecules have one very big added advantage over the biologics, and that is that they are available as oral regimen. So in a patient who of rheumatoid arthritis, if you want, you can combine DMARD and small molecule, and the patient will be able to take these drugs orally at home instead of a biologic where the patient will need to take this drug in a subcutaneous form or a IV form. So what are the small molecules? There are two. First is a JAK1 and 3 inhibitor, that is tofacitinib, and the second one is baricitinib, which is a JAK1 and 2 inhibitor. Among these two, tofacitinib is the one that we mostly use. So let's start with that. You start with a scenario that you have a patient of rheumatoid arthritis. Now, how exactly are you going to start the treatment of the patient? Now, you are always going to start with a DMARD monotherapy. So, and methotrexate is the only drug that can be used as a monotherapy. Hydroxychloroquine can also be used as a monotherapy, but in a very special situation, that is pregnancy, because hydroxychloroquine is the only DMARD that is safe in pregnancy. All the other DMARDs are contraindicated in pregnancy. So unless and until the patient is not pregnant, we'll start with a methotrexate monotherapy. We will initially start with a very low dose of 5 micrograms per week, and we will initially titrate the dose to 20 to 25 micrograms per week. And after the patient has been taking these drugs for 3 months, then we will use this Boolean classification. Now, this Boolean classification is very important because this is how you will assess that whether or not the drugs that we are giving are actually affecting the disease or not. So what exactly is this Boolean classification? So the patient should have less than one tender joint, the patient should have less than one swollen joint, the CRP of the patient should be less than 1, and the global assessment score should be less than 1. If this criteria is not met after giving methotrexate for 3 months, then we have to start the patient on combination therapy. So there are 3 combinations that we can use. First is a DMARD combination therapy where we use methotrexate plus hydroxychloroquine plus sulfasalazine. The second is a DMARD plus biologic combination, which is methotrexate plus etanercept. The third, which is DMARD plus small molecule combination, which is methotrexate plus tofacitinib. However, we have to keep in mind that no matter what combination we are going for, after 3 months we have to again assess the Boolean classification, and if this classification is still not met, what we will do is we will switch from one of these combination to another combination. So for instance, if you are using DMARD combination therapy and after 3 months the patient is not showing the signs of resolution, after 3 months, instead of continuing with the DMARD combination therapy, we will switch the patient to DMARD plus small molecule therapy and vice versa. And we have to also keep in mind that if a patient develops RA flare, we have to add glucocorticoids or steroids for the treatment. And as I already told you, in pregnancy, hydroxychloroquine is the only drug which is safe. So I hope you like this video. And if you want me to discuss the various side effects of a lot of DMARDs or biologics or even the pathogenesis of rheumatoid arthritis, you can comment down below and I will try and make that video. Thank you.